Okay. On page 15 in your new book, okay, so we'll look at this oxygen. We've already talked about oxygen delivery, nasal cannula, non-rebreather, right? Liter flow, what to do. Remember, oxygen is a drug and it requires that you have an order. You can place the patient on oxygen with the order. If the nurse delegates you to go put that patient on a nasal cannula at 2 liters per minute, but you can't take orders. You can't take orders from a doctor. The nurse has to take the order, okay? You can assist with the oxygen, verify the order with the nurse, and go place the patient on the oxygen, but you can't take the order. And then you would report any mental status change from the patient. As you know from the tubing, the oxygen tubing, so to make sure that they don't trip over it and fall, that it's not all stretched out there. I mean, it's not that long, but make sure that they don't fall over it. There's no kinks, right? That they don't light up in the hospital. Oxygen is an accelerator, so burn their face off. Okay, don't want that. Keep the oxygen cylinders away from heat and different things. We know that, right? Keep them laid down or in a holder if they're standing up. So oxygen, not that big a deal. We should know about that. If they're on oxygen for a long time, then they may need padding, like over the ears. So you might take a little 4x4 and put padding. I mean a long time, right? So that would put a little padding there behind the ears if needed, right? Oxygen is really dry, so sometimes they humidify the oxygen. They add moisture to it. Okay, but again, that would be an order for you to have. The non-rebreather mask, the goal in that is to keep the reservoir bag full. So when the patient inhales, the reservoir bag shouldn't flatten. If the reservoir bag flattens out, then you need to turn up the liter flow, right? But just keep that in mind. It shouldn't totally collapse like on TV. You see it just flat, right? Because they don't have any oxygen set to it. That's definitely against the standard of care. It does become dry, so 2 to 6 liters per minute is the normal. But they say in your PCT book, greater than 4 liters per minute may have signs of dryness, so you have to humidify it. Water-soluble lubricant in the nares, because it is dry. We don't want a petroleum-based lubricant because it's an accelerator. If there is a fire, you're just adding grease to the fire, right? So a water-soluble, and then they may need rinsing in the mouth, okay? You have in here signs of hypoxia, so anxiety, fatigue, okay, cyanosis, the bluing of the skin, right, is a late sign, okay? That's what you would get, cyanosis, if you put a non-rebreather on someone without hooking it to oxygen. Pulse oximetry, it says notify the nurse immediately. So pulse oximeter less than 90, yes. Now that's a little bit different than what we go less than 94, right? But keep that in mind. 90%, notify the nurse. Okay, there's just a different range in that. If the tank becomes empty, almost empty, the discrepancy between what was prescribed in the liter flow. So if you went in there and set the patient on 2 liters per minute, and all of a sudden you go back in later and it's on 4 liters per minute, there's a discrepancy on what you set the liter flow at. So go ask the nurse, right? Any sudden change in condition, okay? But this is a great test question here. Do not change or adjust the flow rate of oxygen. Always check with the nurse before removing oxygen from the patient. Okay, so that's going to be one of those. Yep, that's a good test question as well. Any questions on oxygen? Pretty simple. Okay, suctioning, same thing. We've done suctioning. Okay, another what to be cautious of is, coughing, gagging, sneezing, okay? Raise the head to a 45-degree angle. Again, excellent test question. You begin to suction the patient. You raise the head to 45-degree angle if possible, okay? We know the different types of catheters. You have, remember the Yonkers or the hard tip, right? The tubing, the suction unit itself. You have to clear, like if you're suctioning, sometimes you have to have normal saline or sterile water there to suction the water in to clear the catheter. You get the little loogie stuck in the Yonkers, right? And it won't move. It's like an egg. It won't move out of there. So you have to get it out, rinse it out with water. Okay. No longer than 15 seconds, right? Right down here at the bottom. We learned that at the beginning of the year when we talked about suctioning. Why? Why don't we suction for longer than 15 seconds? Vagal, right? Their heart rate starts to drop. So we want to be cautious with that. The tracheostomy patient, the patient with the trach, nasty. Okay, I'm just saying, they don't have a cough reflex and they produce a lot of mucus. Okay, so these patients you want to pre-oxygenate before suctioning. Okay, test the suction. I mean, all this I'm just sort of reading out of the book right quick. Okay, and then advance the tracheal suction cannula until you feel some resistance. So you advance in there until you essentially feel sort of the trachea's resistance. And then here, 10 seconds, right? Suction in, rotating catheter, no longer than 10 seconds for this patient with the tracheostomy. So you have two things that you have to remember. And then in between suctioning, oxygenate the patient. Make sure you re-oxygenate the patient in between suctioning. Any questions on suctioning? I think those are really easy to figure out as well. You have your different monitors. You have cardiac monitors. You have SpO2 monitors. You have all these different monitors that you'll be responsible for. Ventilators, okay? None of them which you will touch. Infusion pumps that are going to start dinging if something's wrong. The cardiac monitor goes off. It starts to ding. What do? Go to the nurse. Let the nurse know, hey, there's something wrong. Okay? You may have training on the equipment, okay? But remember your scope of practice. You can't stop that infusion or turn off the vent or change the vent, change the amount of oxygen, silence an alarm. You shouldn't do that. You want to make sure that you're telling the nurse what to do or what's taking place. Hey, we have an alarm in room 200, right? The pump's going off in 200. You can't change that in PCT land. Okay. Beds, again, we talked about before. Make sure that the bed is the height to avoid back injury. Okay. When you're done with whatever you're doing, maybe you're bathing the patient, maybe you're doing something, you raise the bed up, lower the bed back down. Okay. You don't want the bed up to your height, right? And then Granny decides to get up and go to the bathroom. That's a long fall. You know, she steps out and it's like, whoa, there's nothing there. Then, splat and like, oh no, how am I going to cover this up? No, just don't cover it. Lower the bed down, right? Prevent falls. Make sure that when you go away from what you're doing, that you raise the rails back up, okay, to prevent falls. Also, the rails will help the patient move. So if they have trouble moving, they can grab onto the rail and sort of move over and turn over, right? So you make sure that those rails are up and the wheels are locked when you get to wherever you're going. Make sure the bed is locked. Again, it's a fall risk. The patient tries to get out of the bed and the bed's not locked, it's just going to roll out from underneath them. Wow. A lot like that wheelchair. And then you just think you do a lot of paperwork. You have a patient fall, there's tons and tons of paperwork. If you're in a nursing facility and a patient falls, then the state will come in and do an investigation. Okay? So a hospital, there's still a lot of paperwork. It's a big event that they do. Okay? You have specialty beds, bariatric beds. Everybody heard of bariatric, that term? So people who are obese, morbidly obese, they're considered bariatrics. So they're wider and longer than the standard bed. Okay? You have these beds that circulate water underneath the patient, shifting pressure so they don't, if they're bedridden, then it helps them keep from getting a pressure ulcer. Okay? Flow through there the same way. Pulmonary beds that vibrate and help, they break up mucus in the lungs and help that as well. Okay. And then if you're working there, then you're going to be familiar with the beds on whatever floor. Okay. Feeding tubes, again, they have different types of tubes. We talked about this earlier in the year, right? You have a nasogastric tube that goes up through the nose. Then you have a peritoneal tube that would go through the abdomen, correct? You want to make sure, and these tubes are set there for patients who have trouble swallowing, depending on what type. If it's long term, it's going to be in the peritoneal, that's going to be surgically implanted into the abdomen. If it's short term, then they may use a nasogastric tube. Anyway, this is going to help feed the patient. You can't, the big thing to remember is you can't stop or start anything essentially on your own. You have to have an order to do it. You have to have delegation to do it. Okay? So if the patient's being fed, then if that needs to be stopped for some reason, then you have to go get the nurse to stop the feeding. Okay? And then again, back up to the 45-degree angle. You want them up at a 45. Any breakdown of the skin around the where the feeding tube is inserted, okay? And of course, if the patient starts to vomit, you want to notify the nurse. We don't want, remember that aspiration word we talked about? We don't want the patient to aspirate. Any changes in the amount or characteristics of the material, let's say you're suctioning or something, and you see all of a sudden it's coming out green instead of clear, you want to notify the nurse, right? Any change in condition, you want to continue to notify the nurse. Because remember we talked about it, you're with the patient the most, so you're going to see this breakdown of the skin or these changes before the nurse. The nurse may only go in there once or twice per shift for 12 hours, right? Unless they're giving medication. You're going to be around the patients all the time. Take note where the NG tube is marked. So it's measured in centimeters. So if it's the nasogastric tube, it might be marked like let's say hypothetically 30. So you come back in. I mean, these are details, right? So you come back in, and now it's at 35. That nasogastric tube has moved, so it may not be in the stomach anymore. Okay, so we have to make sure that we watch. We only have 21 centimeters. The trachea is 21 centimeters. Okay, so we don't want that tube coming up out of the esophagus, and all of a sudden now it's draining back in the hypopharynx. That would be one of those aspiration events. Good? Good? Okay. So functional loss, functional limitations, we have a list of them, okay? Developmental, speech, physical limitations, okay? So we want to make sure that we're aware of the patient's limitations. We also, vision. Let me tell you, if you took my glasses away, I couldn't see. I couldn't see you, right? So everybody's a blur.
Same.
So I have this big limitation on my glasses, okay? So keep that in mind. You know, it would be horrible for me to go a day without my glasses. I'd have a bad headache. I wouldn't be able to see, right? So keep in mind these limitations, okay? Hearing limitations, okay? Just because I'm old doesn't mean that you have to shout at me, right? You just may have to, you speak at a normal, and matter of fact, this was one of the PCT questions. You would speak at a normal tone of voice to the patient, okay? You wouldn't shout at the patient, okay? Until you figured out if they were hard of hearing. Then you have to turn up the volume a little bit, right? Then you have to speak a little bit more, okay? If it said something like the patient has a trouble speaking to you or communicating, you would use the picture board. You did a job marker, and you would draw them a little picture or something. That was one of the questions. Okay, I'm not really sure that. Okay. You may just be sitting with them. You may be a sitter. So you guys, some of you guys have seen that, where the techs are sitting outside the room watching the patient, right? It's a job now, that being a sitter. You watch them in case they're suicidal, they harm themselves. They just might be old and they want to get up and wander around. They might have a little dementia, right? Where they need a sitter. So communicate with the patient, communicate with the family. It's important. Some of it is based on, it just takes time. It's just going to take more time that you use. You have someone with developmental delays, don't talk to them like this baby talk. You talk to them in the appropriate, the same way. If they're 18 years old and they have developmental delays, talk to them like an 18-year-old, right? Talk to them like they're two. You shouldn't talk to babies that way anyhow. Use that little baby voice. Drives me insane. But you definitely wouldn't talk to an adult or a patient that way, especially an older patient. So recognize the developmental delays. Your goal, I underlined it here, your goal is to keep the patient safe. Okay? You want to keep the patient safe. Patient safety is paramount. But this is somewhat confusing here because next thing on here is range of motion exercises. Most of the time, physical therapy is going to be doing these range of motion exercises. Okay, that's why it's called physical therapy. Okay, they have you guys doing this, and some of the questions are, how would you use the range of motion of the elbow or the knee or the finger, right? Okay, just think about how it moves. So the elbow is going to be, what's this motion here? This from here to here. Extending. Yeah, this is extension. This is flexion, flexion, extension. Okay? And just speaking from a personal point of view, this would be one of the ones that if I couldn't figure it out by general terms that I knew, I wouldn't spend too much time. I'd sacrifice this question over range of motion. Because there's a lot. I mean, you look at it, and there's a lot of abduction and adduction.
I think you just have to know like the general terms.
Yeah, just general terms. Just flexion, extension, abduct, the way I remember abduct is that it's someone that abducts you. They take you, so they pull you in, okay? And the other one is what? The adduction, so that's just the opposite. Push it away, right? I mean, that's the way I remember those. Extension, flexion, okay? I can't remember the supinate and pronate, but one turns out and one turns in. I think supinate turns in and pronate turns out. I don't know. But those are just, like you're saying, simple terms that maybe, yeah, you might want to look at that. Otherwise, really, I mean, all this is some physical therapy, but you you will have sometimes where you have to go into the patient who is, they're stuck in bed for some reason, and you have to exercise, help them move their arms and legs, right? If they don't, then they come hypertrophic, and they come where they have to learn how to walk again. These muscles will essentially become jelly if you don't exercise them, and then they'll have more therapy later. They have to learn to ReWalk and reuse their muscles. Okay. Anyway, do look over those flexion, extension, abduction, adduction, and the different rotations. In some of you can figure out, supination, turn the forearm and the hand so the palm is up. So supination is out, pronation is in. I had that backwards, right? Supination, turn the forearm and the hand so the palm is down. Pronation. So pronate, you turn in. Supinate, you turn out. Pronate, supinate. Okay, so how would I remember that? Maybe pro towards you. Pro.
It's the supine and pro.
Yeah.
Position.
Oh, there you go.
Or this one teacher, she was saying that she puts her hand like this for soup, so I would like, she won't drop it. So like supinate, like soup, you carry it like this.
Oh, good. Yeah, that's right. Soup, cup of soup. Or, yeah, supine, prone, right? If this is your face, supine, prone, that makes sense too. The soup makes sense too. So, anyhow, just whatever memory device that you need to memorize those, okay? ADLs we've talked about before with the assisted daily, man, I can't even remember what ADL stands for.
Assisted daily living.
Assisted daily living. Okay, thanks. Whew. Maybe I'm having a little old moment. Assisted daily living. All right. How to button things. Canes. Okay. Crutches. Walkers. There's a number of questions about a cane and walkers that we'll just go through when we look at the questions on how high how to use the cane and how to use the walker. Okay, we'll just look at those questions later. Okay, but remember in the ADLs that you want to let the patient do as much as possible, and then you are to assist with that. So don't get impatient that if Grandpa's trying to button up his shirt, and you go, just give it here, let me do it, right? Like your mom and dads did you when you were little. Well, I'm in too big of a hurry. Here, let me do this for you. Well, you never learned to do it by yourself. And a lot of that's therapy for them to keep, dexterity, making sure that they can button their thing, they can feed themselves. Nobody likes to be fed, okay? And really, nobody likes to be bathed, okay, by a stranger. Never say nobody, but most people don't like to be bathed or fed, right? So, anyhow, keep that in mind. Let the patient do as much as possible. And then you should just go through the list here, okay? Walkers. Here it is. 2, the hand grip should be at the same level as the patient's hips. That was a question on the review, okay? So, the cane, let's see that cane. Bear weight. Canes, they're appropriate for patients who can bear weight but have weakness on one side of the body. The cane should be at the level of the patient's hips. Okay? On the strong side or the weak side? Weak side. Right? There's no reason to put the cane on the strong side, but put the cane on the weak side. Those were questions in there. One of your big things that you will be doing as a PCT is to call it rounding. Okay? That's not like 0.5 to the nearest number. It means that you go room to room and you do rounds. Okay? And you check on the patients. This one, it reduces the amount of falls. Okay? We haven't got to it yet, but there's questions on how often do you, if you have a patient in restraints, how often do you go and check on them? One's like every 12 hours, one's never, these different things. So it's like every hour. No, that was wrong. I got it wrong. It's like every 15 minutes. You have to go in there and check on them. And then you have to release the restraints every so often. That's in the rationales. Okay, so those type of questions, they're not covered in here, so we have to read the rationales and study those. Okay. Anyway, you go through and you check on the patients. One, this decreases them hitting the call lot. It lets them know that you're engaged in them, that you're there for them. So it's going to increase their satisfaction, their stay. And then you check on things that change, right? Level of consciousness, shortness of breath, increased pain, incontinence, savvy incontinence. It's a vocabulary. What is that? Patient's incontinent.
You can't do stuff like for themselves.
No.
What is that?
Let me give you a hint. It's either to bladder or bowel.
They can't control.
But they can't control. They're incontinent. So they someone that's incontinent of the bladder, they don't have any good control over their bladder functions. Okay. So they essentially urinate on themselves. Even if the patient's emotion, if they're upset, that's something that you would want to report to the nurse. That way you're rounding, you're taking care of the patients, right? You're looking for their needs. There is nationwide, there's this hospital consumer assessment of healthcare providers and systems survey. Okay? They just take a survey over how was your hospital stay. Remember, a private hospital, they can go to any hospital, right? So this is real important in a private facility. I mean, if you were treated like dirt in a private hospital, would you go back?
No.
Or would you go to a different hospital?
Different.
Yeah, of course, you'd go to a different hospital.
You take
Right, so removing an IV catheter is pretty easy, right? And that's a PCT task. They go in there and they say, "Hey, remove the IV in room 2." Okay, it's very quick. Remove the catheter. Make sure that it's the right patient. You don't want to remove the catheter and all of a sudden they go, "Oh, whoops!" Right? You know, wrong time to remove it. Make sure that the provider has prescribed discontinuing the infusion, okay? And then there's the steps of it, you know. Take the roller clamp, cut the infusion off, okay? Start removing the tape around the IV catheter, and then essentially put a little pressure on there and remove the IV catheter and hold pressure on when you remove it. Make sure that the IV catheter is intact. That part is a biohazard, so that would go in. It's not a sharp, it's just a biohazard, right? So that would go into a red bag, and then you would continue to hold pressure on there, okay? If the part of the catheter is broke off, that could create an embolism, okay? Catheter shear, so that would definitely be reported. Pain, redness, swelling, where it looks infected, okay? If a hematoma formed, what would you do? Put pressure on it. Just keep putting pressure on it. What's a hematoma? Yeah, it's a collection of blood, blood under the skin. When you remove it, remember, you remove the IV catheters, there's a hole in the vein, so you have to put pressure on there enough to keep till it clots off, till it forms clot, stops bleeding. Here's a good test question. Apply pressure over the insertion site 2 to 3 minutes. Okay? Apply gauze to the side or bandage or whatever the protocol is on there. Okay? So you would apply something over the site. You just wouldn't leave the empty hole out there. You put a Band-Aid or a gauze pad over it or something. 4x4. But that 2 to 3 minutes is key, like a key question. How long do you apply pressure? 3 minutes. Look for these different things, like the sheared catheter. We doing okay?
Are you?
I'm doing good. Let's see where we're at. You ready for a break? Okay, let's take a break.